Support for The Painful Truth is made possible in part by the Healthcare Foundation of Greater Kansas City, eliminating barriers, promoting quality health, and by the Reach Healthcare Foundation, dedicated to improving health coverage and care for the medically underserved.
We've become a pill-popping culture. Nearly 60% of Americans take a prescription medication every day. 1 in 7 of us take 5 or more. On this Week in Review Health Special, we ask, at what cost? The addiction and abuse of prescription drugs robbed the lives of 16,000 Americans last year. That's more than those who OD'd from heroin and cocaine combined. Nearly 1,000 of those deaths were here in our bi-state. Yet Missouri is the only state in the nation without a prescription drug monitoring program. Would such a fix make a difference? This half hour we get at the painful truth as we unbottle prescription drug abuse and addiction in the heartland. We're on location at UMKC, partnering with the American Public Square. With us are health and political leaders, including Holly Rader, a Republican state lawmaker from southeast Missouri, who has experienced the trauma of prescription drug abuse in her own family. She's led the charge to pass a prescription drug registry program in Missouri. Her Republican colleague in the Missouri House, Jay Barnes, is adamantly opposed to drug registries, citing privacy concerns. Myra Christopher at the Center for Practical Bioethics worries that restricting prescriptions will make it harder for millions of Americans living with chronic pain. And Sherry Green is the president of the National Alliance for Model State Drug Laws. She's flown in from her home base of Santa Fe, New Mexico, to join our discussion. Let's start with you, Representative Rader. You're not just a lawmaker. This is personal to you, isn't it?
Yes, it is. At 17, my daughter, who worked at a local restaurant, excellent student, she cut her thumb at work, went to the emergency room to get it stitched up. They gave her a prescription of Loracets, and after that, she just started buying them.
How did you know she had a problem?
Her personality changed. Your highs are very high, your lows are very low. The spiral is very quick, and so before too long, she went from prescription pills because she couldn't afford them any longer to meth, which was very prevalent in our area at that time. And so I very much understand how easy it is to become addicted and how innocent many become addicted.
Well, Sherry Green, we've heard one story. I've read also that there is no common story. No two painkiller addiction stories are alike. They're all different. So are there any snapshots you can provide for us of who is most at risk, who is most affected by prescription drug abuse in this
As
country?
many of you probably already know, last year almost 19 million people used prescription drugs in a non-medical way. And according to the National Institute on Drug Abuse, when they researched 2014 data, what they found is that our young adults from 18 to 25 are the ones who tend to abuse most opioid pain relievers. So we have a prescription drug problem that is very much centered on our young adults, our next generation of decision makers.
Are painkillers just too easy to obtain? Is that the issue, Myra Christopher?
Depends on who you are. For those who live with chronic pain, they're increasingly difficult to access, and I'm particularly concerned about the approximately 30 million people who live with high-impact chronic pain, whose lives are also destroyed when they don't get proper care and the kind of treatment and respect that they deserve.
So when we look at the local context for this conversation, yes, we see it as a national issue, but we hear about, and we see the headlines, that Missouri is the only state in the nation that doesn't have what some people view as one of the most important solutions to stopping people pill shopping, and that is to have a prescription drug monitoring program. Jay Barnes is in the Missouri legislature representing Jefferson City, is alarmed by that prospect and doesn't want that to happen. Why?
Ordinarily in this country, when we try to look at somebody who we think might do something wrong, there has to be probable cause before government takes any action to monitor what they're doing or takes any action against them. And the PDMP turns that on its head and says, no, just because you get a prescription for a certain drug that you may need, automatically that puts you on this list, which is some sort of attaches some sort of stigma to a person and which ultimately cannot be safe long-term from hackers.
Holly Rader, you're the person who's trying to advocate for this position, to introduce legislation in Missouri. Help us understand, what did prescription drug monitoring program do? Who is doing the monitoring?
This is an extension of your electronic medical record. It is so that your physician, so that your medical professional can have that full view of what their patient's history is, of what their patient is on. Now, in order to have this, you have the state that would be the maintainer of the information. So they're not allowed to go in and look through it either. The majority of this...
Well, when we say the state, I'm sorry to interrupt you, what does that mean? Who actually does this monitoring?
We have the Department of Health and Senior Services listed in our bill. They're not allowed to go on a fishing expedition in this information either. Now, the pharmacist and the physician have that medical information to be able to choose to write this prescription or fill this prescription, or if they see that, hey, they've gotten 5 prescriptions in the last week and a half, this is going to throw up a red flag.
Okay, so 49 states currently have some form of this, Sherry.
Correct.
Okay, and so what has their experience been? Have they seen a lowering of prescription drug overdoses, a lowering of people addicted to prescription painkillers?
Yes, they have. Professor Patrick from Vanderbilt University and some of his colleagues, they actually released a study this summer. And they studied 35 states that had PMPs, and they looked at what happened after they implemented their PMPs. And what they found is that those states actually saw a reduction in their opioid overdose-related deaths after implementation of their PMPs.
Myra Christo, you've also been looking at some of these studies, but you're not as convinced.
I'm not. There are lots of features and kinks in these things that we haven't worked out. We don't have interoperability between these things. We sit in a place where you drive a half mile and you're in another state. I keep pushing for model legislation, that if we could ever get to a place where we have some agreement about how they are overseen, how they are monitored, who has access, who doesn't have access, then I might be very much in favor of them. But at this point, I don't think we have sufficient data yet, for me anyway, to get on a bandwagon one way or the other. I think we need more data.
Well, let me ask Representative Barnes, you expressed dismay, alarm over the privacy concerns. Yet we have 49 states in the nation, many of them Republican-controlled, most of them Republican-controlled. Where is that national outrage in those other states about those privacy issues? Why is it only in Missouri that you're seeing that outrage?
Why is it only in Missouri that we're seeing that outrage? I think there likely are other people in other states that have those views. I'm not sure that, I'm not familiar with the study from this summer. I know of at least one study, it's Prescription Drug Monitoring and Drug Overdose Mortality, which was published in Injury Epidemiology, that found PDMPs did not reduce drug overdose mortality in most states where they were implemented. But even if they're marginally effective, the underlying issue, do we want to live in a society where everything you do every single day is tracked?
You're of the same party, Representative Rader. How do you respond to those concerns then from members of your own party? And Representative Barnes isn't alone in his feelings about privacy.
Yes, and I'm very concerned about patient privacy as well. I think the federal government addressed this long ago with the HIPAA laws. All that we're doing is we have archaic laws in Missouri that doesn't allow our physicians to make true informed decisions for their patients.
In your bill, does it require physicians to actually check the database?
It does not.
And that's what I found. No state is requiring the physicians to even check the database. Physicians are incredibly busy, Ms. Green. So we can set up all of these laws. Would it make a difference if the physicians haven't got the time to even bother to check the database to begin with?
True, and a lot of state legislatures decided to allow a physician, a nurse practitioner, so they don't have to use their time to actually delegate another person in their practice to be able to access the information, just as those individuals actually gather other patient information.
We can get caught up in these prescription drug monitoring programs. Some people, though, have a lot of other solutions for fixing this whole issue of prescription drug abuse, and we're going to get to those in a moment. But I want to turn this to you and our roving reporter, Stephen Steigman of KCUR News, who has been scouring our audience with questions here at Pearson Hall at UMPC.
Scouring sounds so evil. And Myra, Christopher, this is for you, but could be answered by other members of the panel. Could you provide an example of the difficulty with getting legal pain medication, and are those examples outside the arena of medical insurance?
A major barrier is fear among physicians now, particularly primary care physicians, that they are under scrutiny from their state medical boards, from local law enforcement, from state law enforcement, from the DEA and others. It has become so tedious and so cumbersome that many primary care practices now have signs at the reception desk that simply say, "We do not prescribe opioids." Other issues are in response to recent guidelines that are voluntary that were published by the CDC, which recommend limitation on the number of days for which prescription should be or could be prescribed, and also dosage limits. So there is a kind of a perfect storm for the chronic pain patient. So the questioner asked about insurance. Frankly, the easiest thing to get an insurance company to pay for is an opioid prescription. It's the easiest thing for a primary care doc who has 7 to 15 minutes to do. We know that what people with chronic pain need, sometimes it's behavioral health therapy, sometimes it's chiropractic, sometimes it's acupuncture, sometimes it's diet and nutrition counseling, but what third-party payers pay for is opioids, interventional procedures, and surgical procedures. They will not pay for comprehensive chronic pain and complementary therapies.
Could I just say, that because we are talking about the barriers there and the price, I did see there is an addiction center on the Kansas side of our state line that said they have people, it's not uncommon for people coming into their program to spend $200 to $300 a day on prescription pills. So it requires money to do that. This is not a poor man's then addiction.
And that is why we see so many that move to heroin or methamphetamine, because once they cannot afford the addiction any longer, they move to the less expensive drug. And you know, heroin is available in pill form now, and so it's not near as scary.
There seems to be an awful lot with prescription drug monitoring programs of the sense of we have to monitor the patients. Some people believe, what are we doing about doctors? They're to blame for this, aren't they? That's where the problem lies. Doctors are too fast to prescribe medications without fully explaining the side effects. And why are doctors prescribing them so often? Is it, Representative Barnes, because the pharmaceutical companies are giving them incentives to be giving all of these painkillers to patients?
Well, I think if you look back at the time in which opioids spiked in use, if you went back 20 years, the general medical thought was that opioids were only appropriate for very short-term acute pain and for end-of-life care in cancer. And I think what you saw was a push to start using them for chronic pain. The CDC report referred to earlier noted that they didn't find any study that has ever shown opioids to be effective at treating chronic pain.
The reality is we don't have data. It doesn't mean that it doesn't work or it does work. But what I want people to know is that since 2010, opioid prescribing has gone down. The rate of substance use disorder and addiction has not declined. It's gone up. It continues to go up. So I get so frustrated that we never get to root causes. I mean, I think we need to be talking about why is it that our kids 18 to 25 years old are trying to escape with these medications.
I get frustrated, Myra, that when we have conversations and we don't have practical solutions that you can get your arms around and say, okay, that's something that fixes something. So we talked about the prescription drug monitoring program. That is Representative Rader's approach. She's tried to push this now for several years in the Missouri legislature. It has not gotten anywhere. Representative Barnes is one of those opponents. So what is your solution then? If it's not a prescription drug monitoring program, you've heard some of the concerns. What is your solution to fixing this?
Three things. Number one, I've sponsored a bill that's an alternative to a PDMP that rather than tracking everyone's prescriptions, if there's probable cause to believe that someone is abusing opioids, then they can be placed in a database. And the database can be checked by doctors. If they suspect someone of doctor shopping, they can check that database of people for whom there's a reasonable suspicion of opioid abuse.
Okay, let's stop there for a second. Would you support that, Representative Rader?
I do not.
Okay, what was the problem with that?
It's very much just playing into the stigma of addiction and mental illness. It's not a law enforcement problem. It's a medical problem, and it's a health epidemic. And so we need to look at it.
That was one potential solution.
Nick, let me be clear.
Okay. Yes,
Law
please.
enforcement would not have access to this list except to the extent that a person convicted of a drug crime or who has lost their children because of drug abuse would then automatically be reported to the list.
I know that Representative Barnes has other solutions, but we're going to get to those because you are much more important at this moment in time because you're the fifth panelist on this program, Stephen Steigman.
How does Representative Barnes reconcile pseudoephedrine tracking and its positive impact on Missouri meth use and the likelihood that PDMP could have the same positive impact on opioid abuse?
No, I did not support pseudoephedrine tracking either. I don't think you should have to sign a book because you have a cold or you have the sniffles in the spring. The effectiveness at shutting down Missouri's meth labs, I also think that is, I might call a fact check on that as well, whether we've actually slowed meth production in the state of Missouri or not. Number one, just in general, and number two, because of that law.
Do you support loaning a book from the library because they can be tracking your reading habits, Representative Barnes?
I think every librarian in the country would agree with me that the government should not have a database of the books that people check out at their libraries.
Okay, Stephen Steigman over at KCUR News. We are thirsting for your questions.
And this is from Andrea Murphy from Kansas City, Missouri. Have doctors in Missouri asked for a PMP system?
Absolutely, yes. All of the
More than one?
yes.
Lots of
Yes,
of doctors?
Their associations lobbied on behalf of this.
Not all physicians are created the same, and there are physicians who are far more fast and loose in giving away prescription opioids in great amounts than others. And we did see earlier this year a Los Angeles doctor sentenced to 30 years to life in prison after being convicted of murder in the overdose deaths of patients for whom she overprescribed painkillers, is prosecuting doctors whose patients die of prescription medication overdoses an effective way to combat opioid addiction. Representative Barnes, you're an attorney.
Perhaps a civil lawsuit I can understand, but I'm not sure about, I don't think it's a good idea to be prosecuting doctors except in the most egregious circumstances. I think to sort of broaden the issue here, if you look at the Los Angeles Times, they've done a series on what drug companies knew, in particular what they knew about delayed release tablets and how it led to higher rates of addiction. And rather than fix the problem, they continued to market the delayed release tablets that they knew people would be addicted to. There are stories out of West Virginia about drug companies knowing exactly who the bad doctors were because they were sending the marketing representatives out to sell more pills to those doctors. And what's happened to those drug companies? Not a whole heck of a lot. The third thing
Isn't it up to state lawmakers like yourself to be looking at those issues and to be putting that pressure on pharmaceutical companies, putting legislation in place?
Frankly, I don't think state lawmakers have the guts to do that.
Nick, your question about prosecuting physicians, I want to point out that the case in Los Angeles is an N of one. It's the only instance we've had in the country where a physician has been criminally prosecuted and convicted of murder. And if you read the facts on that case, I would argue this young woman was not acting as a physician. I don't think she even deserved to be called doctor, anything. She wasn't even examining her patients. So I want us to be really careful about using those sort of outlying cases Bad cases make bad law, we say, but bad cases also make really bad ethics. So I want you to get over the notion, Nick Haynes, that what we need to do is just find those bad doctors and throw them under the jail or sue the ones that aren't practicing very well.
Myra, you have talked about your concerns about prescription drug monitoring programs. You've talked about, going after doctors isn't the problem. So what is your solution then that is going to make any dent in the kind of statistics we're seeing with regards
And
to prescription
I
drug
have
abuse
data.
that somebody like Representative Barnes can actually run with?
We now have two major federal reports, the IOM report, the National Pain Strategy report, that say the solution is to turn to comprehensive chronic pain management. We have data from the mid-'80s that it works. We have data from the mid-'80s that it is cost-effective.
Okay, most of us who are not in the health field don't understand what comprehensive pain management is. What does that mean
By
in
that
your
I
elevator
mean,
speech?
it may include medical therapy, opioids and other medications. It may include surgery, but it also includes behavioral health and complementary therapies that are evidence-based. Things like chiropractic, acupuncture, diet and nutrition counseling. But nobody pays for it.
Okay.
Comprehensive chronic pain care, let me make one statement, then I'll be quiet, is like hospice care. It's very expensive up front. It's front-end loaded, but it's very cost-effective long-term.
Well, I think Myra raises some interesting issues, and I don't know how we put that into legislation, although I'd be
I'm
interested.
sure she'll help you.
I would
I'd be happy to
I
help
would be
with that.
very interested in hearing those things, because I think there is a universal agreement here that options other than opioids need to be tried first.
But you would be open to that?
Absolutely.
We've talked a lot about Missouri. Kansas, though, ranks relatively low in overdose deaths, but the group Trust for America's Health recently named 5 states where youth drug overdose deaths have quadrupled in the past decade. These are people from 12 years old to 25 years old, and Kansas was one of those 5 states. Stephen.
Are there any studies that link legalized marijuana use with an increase or decrease in opiate abuse and or overdose?
Actually, there was a study that was released in May of this year. It was a study that the Rand Corporation was involved with that actually looked at legalized medical dispensaries. There was an association between those particular dispensaries and a reduction in dependence on opioids. The other aspects were somewhat less positive and probably negative in some people's mind, which was there was an increase in marijuana dependence as well as an increase in recreational use with adults.
And a new study released this week by the American Journal of Public Health claims that states that allow medical marijuana to be used to treat pain show a decline in the use of opioids. So will we be seeing legislation on that front in the state of Missouri, Representative Barnes?
There was a resolution to place something on the ballot that would have allowed marijuana to be used in very limited circumstances. I supported that legislation. You need 82 votes to pass in the House. It's got to pass twice, though. First time it was voted on, I think it got 85 or 86 votes. Prosecuting attorneys of this state got their ears up. They came down, they started making phone calls. By the time we voted on the bill again, we had something like 72 votes after they had started working the telephones. We are a very pro-life state, and we were talking about someone dealing with pain at the end of their life from cancer treatment, person who cannot eat because of their illness, that absolutely it is something that this state needs to look into, and to do anything less shows it is a complete lack of compassion for folks in that position.
Representative Rader.
I was a no on both counts on this bill. It had a clause in there that with the signature of, I think it was 10 physicians or 12 physicians, you could add another medical ailment to the list of things that you could prescribe this to. We need more studies. We need to make sure that it's extremely narrow and is going to stay narrow to these very important end of life. We have to be extremely cautious on how broad this is.
Yes. Myra, I didn't hear your perspective on this.
We do know that for some people with loss of appetite associated with cancer and other diseases, some people with neurologic diseases, children with seizures and so forth, it can be very effective. But I want to comment on the statement you made, Jay, about, if we're talking about people who are dying or people who are living with cancer pain. I don't understand why that's okay, but it's okay to deny a child who's been born with some terrible form of rheumatoid arthritis or the cancer survivor. The reality is that your brain doesn't know cancer pain or end-of-life pain from broken bone pain. So I don't get the distinction, because I've come to believe that those who live with chronic pain have a greater burden to bear than do those who are actively dying. Those who are actively dying at least know that an end is in sight. Relief will come.
Nick, if I might, I think there is a distinction. There's a cost-benefit analysis that goes on, and the cost of an end-of-life patient having that treatment just at the end of life, there's not the risk of the long-term addiction and the problems that come with the long-term addiction from the person who has it at the end of their life versus a person who is not at that stage.
Jay, here's a problem you're going to have. Average American today dies of multiple chronic illnesses in advanced age. We don't know who's dying anymore.
Hoping to curb America's epidemic of prescription drug abuse, Congress in July passed this very comprehensive bill called the Comprehensive Addiction and Recovery Act. Finally, our representatives and senators were going to do something, and they were going to finally lick this problem. Then they went on vacation without actually funding the law, and we've never heard anything about it since. Now, the president wanted more than $1 billion to go towards this that would improve access to treatment services, include language to allow cities and counties to pursue their own local drug monitoring programs. Now, you've never allowed local cities to have gun control measures. You've not allowed to have local cities to pass measures even restricting plastic bags in the state of Missouri. Would you be opposed to allowing cities to impose their own prescription drug monitoring programs separate from the state, Representative Barnes?
I'm not any more or less confident in the ability of the city of Kansas City to protect that data than I am the state of Missouri. I don't think it's appropriate to have two different standards. I don't think that the citizens of Jackson County ought to have their privacy rights invaded by a local ordinance, just as I don't think the citizens of my county, Cole County, should have their privacy rights invaded by a state statute.
And I would argue that it's a well-intended but very misguided effort, that those resources could be redirected to other strategies that would be have a much better chance of being successful.
Just name one.
Education of physicians, education of patients who live with these problems, both substance use disorders and chronic pain.
Holly Rader, by the way, Sherry Green, Representative Jay Barnes, and Myra Christopher. Thank you for such a civil conversation on prescription drug abuse.
Support for The Painful Truth is made possible in part by the Healthcare Foundation of Greater Kansas City, eliminating barriers, promoting quality health, and by the Reach Healthcare Foundation, dedicated to improving health coverage and care for the medically underserved.